Okay, recording has started. All right, so everybody make sure you put your name and your EMS number in the chat so that there's a transcript of it and I can add you into the onto the roster. Tyler, can you hear me? Oops.
Yeah, we can hear you.
Okay. Can you point your camera towards the screen so everybody can see it? And Dr. Wilson?
Tom, can you see the screen?
I cannot see the screen.
Oh, he's looking at you.
I'm seeing you, LT.
Can you see the screen now?
Yes, I see the screen now.
Do you know which source do you use off the?
Everything's off there, Tom. Do we?
Is the computer on?
Yeah. And we have the doc's
My
computer.
laptop's on and then the computer's on.
When you turn the camera on, it automatically defaults to the computer that's inside that little roll around kiosk thing.
Yeah. So we're plugged into that with the doc's computer, with his laptop.
Oh, I see. I'm not sure because I usually just plug his thumb drive into that computer.
Oh, okay. Yeah.
Well, let's try that. So
Yeah.
We can do that.
take that.
You say
Can
what?
you-
Up front. There's.
Oh, this one's up front too.
there's ports
This one's
up
up
front.
But the projector is normally already preset for that computer.
Yeah, it's not. So I'm trying to go through all the sources.
I don't think it uses the HDMI. It probably uses one of the two computers.
So this would probably be.
Let's see if that. Oh, wait a minute. Maybe.
Or maybe one.
Hey, we're getting somewhere.
So,
It's only taking 20 minutes.
Sorry. Mix up on my end. This is my fault. I apologize to everybody.
so this, so where do we find?
What's
Yeah.
Just makes for a shorter class.
what's that?
Makes for a shorter class.
Oh, I think we got it.
Here we go. Yeah.
So we got to set you somewhere where you can see this, right?
Yeah.
Get to be the
Oh.
obligatory phone holder.
You get to be the holder.
Oh,
Yeah.
jeez, thank you.
Now, can everybody out there hear me all right?
The audio
Yes.
is a little low, but I can hear you.
Okay. Yeah, thanks for bringing everybody up there, Tom. Appreciate it.
Yeah, my apologies. Again, this is my fault. I apologize to everybody.
Oh, that's all right. We'll make it happen. Yeah, Tom, thanks for your help. So,
I
need to
just
face-
broke a couple things though.
Facing your phone.
I'm gonna face it towards you. We just need to.
Oh, yeah.
You guys can see okay back there?
What I'll do is. Oh, I think we can do this.
I just moved down. Yeah. I said I didn't want to hold it the whole time. I'm not gonna lie to you. I was looking for something to like lean it on or something. That's all right. Yes, sir. Thank you.
Yeah. All right. Yeah. Yeah, thanks, everybody. I appreciate it, guys. Okay, can everybody see me then?
They can see the screen, dog.
That's the screen is most important. Yeah, look at me.
Let me see if I can get them even closer.
If you guys look at me long enough, you'll be Zofran. It's like that show, Naked and Afraid. If you saw me naked, you'd be afraid. Yeah.
Can everybody see the screen okay?
Yep.
Can everybody hear Wilson okay?
Yeah, can you hear me all right?
I
Yep.
hear you here.
Yes. Good, we're sailing. All right, thanks everybody for your patience. I really appreciate it. Yes, the boys in the back come up. Yeah. Thanks, sorry for the delay, but tonight I will go over some pain management in the pre-hospital setting. Things have changed in the last several years. When I first did this, ketamine was just a dream for EMS, and fentanyl wasn't even out for EMS use. That tells you how long it's been since I talked about pain management in the field. So I thought I'd review that. No matter what your level, whether you're just EMT or paramedic, it's really good to know what tools are in your toolbox and how we can treat pain. We treat pain largely non-pharmacologically by not using drugs at all. That's just a simple splint on a fracture or maybe ice eyes to a bruise. It's non-pharmacologic. Pharmacologic can be anything from ibuprofen or Tylenol to Dilaudid. So we'll discuss all those avenues. We'll go over dosing. I'll point out some good characteristics, some bad characteristics, and kind of dispel some myths as far as pain management goes. And then Tom, like always, will segue into the second part of the presentation, and do some case reviews. Okay. So that's me. A good definition of pain. Oh, is this not advancing on the screen? There, that's better. It's an unpleasant sensory and emotional experience that's associated with actual or potential tissue damage. That's really important to know because pain is an actual feeling, but unfortunately it mixes very, very well with our emotional centers. And you guys know as well as I do that for you, an 8 out of 10 pain can be really something like a kidney stone, but for another patient, an 8 out of 10 pain is just a hangnail on a finger. So it really varies. And the reason it's so hard to figure it out is because there's so much emotional overlay in pain. So that's what makes it hard to quantify. We'll talk about pain scales in a little bit. But this definition, even though it's 1993, is pretty much held through the literature all these years. So we'll go on here. Pain comes from two sources, and this you guys probably know. It either comes from the viscera, which is your organs, and that's gallbladder pain, appendix pain, kidney stone, that sort of thing, or is somatic. So if you get hit with a baseball in your shoulder, that's somatic pain. If you dislocate your knee, that's somatic pain. So it comes from the soma, which is a Greek word for body, and visceral is actually, it refers to hollow organs. The thing with the visceral pain, I think I have a slide to this. The visceral pain is, this is weird, huh? Get used to it. The visceral pain, you guys, is widespread. It's not specific because the autonomic nervous system has multiple fibers and multiple levels. It can't isolate the pain. That's why some folks with appendicitis will be the classic textbook right lower quadrant. Some folks with appendicitis will be just around the belly button. Some won't have any pain at all. Some may have hip pain, back pain, and same way in cardiac pain. You guys all know that chest pain or an MI doesn't always have to be substernal chest pain. That's a pressure or a crushing sensation. Sometimes it can be neck pain, jaw pain, pain in the shoulder, no pain at all, shortness of breath. It's weird. So visceral pain is in the exact science. Somatic pain, however, is pretty specific. If somebody smashes your left thumb with a hammer, it's your left thumb that really hurts. You can isolate that. You know where that is. If you get hit with a baseball in your right hip, you know your right hip hurts. So there's a difference between those two pains. We all know the definitions between acute and chronic pain, but interestingly enough, a lot of us want to put chronic pain in under that 6-month thing. A lot of us think if a patient's had pain for 4 weeks that it's chronic, and by definition, that's not quite so. The reason it's important for us to know is for us not to hesitate to treat what we think as chronic pain in the acute setting. Now, believe me, there are patients who have chronic pain. Let's say it's a spina bifida patient with lumbar stenosis, and they've had pain for 3 or 4 years now, but they have a fall in their living room. The fall has exacerbated their chronic back pain. Now they fall in the acute pain category, even though they have underlying chronic pain. And a lot of us, both in the pre-hospital and hospital setting, are hesitant to treat that pain because we look at them like, oh, they're already on OxyContin and oxycodone every day. Why would they be hurting now? What makes Sunday night in the middle of my night shift so much different than any other day of the week? So it's easy for us to steer our minds around that, and that's why I point this out. So both the definition and the chronic pain falling and getting acute pain just something to think about. So our pain sources give us different perceptions of pain. I thought this slide, I made this up. Hope you don't mind. It's kind of crude, but it's Danny Boy trying to do tech. Cutaneous or deep pain is very typical and described as sharp or burning, dull or aching. So if it's an intense pain like this, it's often due to something along these lines. It's a wound, you know, either self-induced, accidental, a surgical wound, a burn, that sort of thing. That gives you that burn or an ache or sting or sharp pain. So typically in the acute pain, these are the sources that would give you this description. So if the patients are describing their pain as dull or aching or cramping, it certainly could be in this category. Now, why is it that MI pain, myocardial infarction pain, would be described as a dull or aching pain or pressure in the chest? That's because the heart's a muscle, right? So muscle pain, the heart is not functioning right because it's not getting its oxygen. So any muscle that doesn't get its oxygen is going to cramp up. If any of you in the room have had leg cramps after a good run or a sports activity, or waking up in the middle of the night because your electrolytes are depleted, you know how painful that is. I mean, that's awful. So that's what the patients are experiencing. So these are just some evidence of acute. Chronic pain that can cause these same symptoms are things like arthritis, osteoarthritis, rheumatoid arthritis, metastatic cancer pain to the bone. These patients will describe a deep aching sensation. Can you imagine living with that day in and day out for years? You know, patients with bone mets are often very uncomfortable. LBP refers to low back pain. Not that we ever see that, but you know, very strange. So a cutaneous or a deep structure, either one can cause those symptoms and present that way. Organs or lining of body cavities, like the lining of the stomach with an ulcer, the gallbladder, the inside of the urinary bladder from urinary tract infection, will give the patients more of a diffuse or deep pain. The burning that patients describe with a urinary tract infection is when they pee. That's dysuria, and that's epithelial pain as the urine that's contaminated passes through the urethra. So that's that burning that you classically hear patients tell you about. But if they're not peeing, they will feel like a dull ache or cramping, and they will be tender over the bladder. Same way with kidney stone. Sometimes if they're not acutely passing the stone, they may have some ache, dull pain over the kidneys. Same thing with pyelonephritis. It's a good clue when you're examining them to punch right here in the CVA area. I'm standing in front of the camera there for everybody. Poorly localized, you can't localize it to one area. In the acute phase, this is often due to chest etiology, abdomen, something deep in the pelvis, organs that are distended like a bowel obstruction. Bowel obstruction, they hurt everywhere. Well, what quadrant? Well, I just hurt everywhere. I cramp everywhere. Diverticulitis can present this way too. Typically, it's left lower quadrant, but often it can be other places too, or widespread. Just depends on the involvement of the colon. Chronically, if you get this description, it's chronic pancreatitis. A lot of our alcoholics, patients with hypertriglyceridemia, elevated cholesterol, chronic kidney or gallstones, can present with chronic abdominal pain that gives them this stabbing or poorly localized pain. So any organ pain deep inside can give you this description. What about nerve pain? Nerve pain is a different critter because nerve pain is a disturbance of conduction underneath the myelin. The myelin covers the nerve. It's kind of like the coating over a cable, for instance, or an electric cord, and you peel the coating off and you have the wires underneath. That's what the nerve is. The myelin is affected with disease, either acute or chronic, or injury or infarction. And often it will give you this description. The patients will describe very sharp, shocky, intense lightning. They'll describe it as an electric pain sometimes. Patients with neuropathy, for example, or acute nerve compression from a ruptured disc will tell you that they're getting lightning pains down their leg. How about the patient with acute trigeminal neuralgia, where they have nerve pain of the fifth nerve? It comes into the face, and they get these tics, these lightning, sharp pains, and they're calling you for pain. You walk in, and you see this woman or man, like this, and you think, man, they're weird. Something's going on, and they're getting these very severe lightning pains. Dental pain can cause this too, because dental pain feeds back on the facial nerve sometimes and gives them these fiery, shocking pains. Phantom limb can do this. So if a patient's just had an amputation, even if it's just a few weeks or even a few years down the road, the patients can get phantom limb. The body still senses the remainder of the limb that's now missing. Soldiers during the Civil War experienced this all the time. And they used to think that the soldiers were going crazy, and I forget what the term was, but they thought it was a mental illness secondary to the amputation, and actually it was later described in the late 1800s as phantom limb, because the nerve endings, when they got cut, are raw, and when they heal over, they scar. They actually scar over, and it's the scar tissue that's stimulating the nerve. It continues to do so. So nowadays we treat it with medicine, or they can do reconstructive surgery and actually fry the nerve endings. You couldn't do that back in the 1800s. So in the acute phase, it's often post-surgical pain that's doing this. Very common when tissue has been removed. It's an amputation, it's a mastectomy, it's jaw reconstruction, it's something pretty large. In the chronic phase, we see a lot of this. Diabetic neuropathy is very, very common. It's more common in type 1s than in type 2s, but type 2 diabetics can get neuropathy as well. Why? Just FYI, it's because of the chronic influence of elevated sugars that actually eats away at the myelin across the top of the nerve ending. So the nerves get raw and they stay that way and they never heal. So pretty sad. And it's chronic. These patients can be treated, but unfortunately, we can only get them to a certain point. You can't get rid of it, which is really sad. Same thing post shingles. Unfortunately, my brother-in-law has this. He got a really bad case of shingles in the scalp and into the face, and once that healed, he's got neuralgia on the trigeminal nerve, from his shingles, and he gets these tics that are just horrible, really miserable pain. So this just gives you an idea of pain sources, where they come from. Why am I spending some time on this? Because the description that patients are giving you may steer your ship and help you figure out how you're going to treat this. Why do we undertreat pain? Everybody knows the hesitancy we all have of giving patients narcotic analgesia. Some of us don't. I am kind of a little liberal in the emergency department, and I hope you guys lean a little bit that way, because you and I are seeing the worst of the worst, right? When you really look at the broad scope of emergency care in the pre-hospital and hospital setting, you and I most of the time are seeing acute pain, correct? Or acute on chronic pain. The patients are calling 911 for a reason. They hurt, and their hurt is beyond what they can do. They may not have approached it right. They didn't take the Tylenol. They didn't try their gabapentin. They got off their OxyContin for whatever reason. But no matter what the excuse or the story, they're in our hands now. So it's our responsibility to address it with an open mind and a kind heart. So we don't have a good visual. We often have a closed head as far as what we call closed bias. We want to close that off and think, nope, this patient has been to Clear Book 3 times this year for rehab. I'm not going to give him any narcotic analgesia, even though his leg is filleted open with a fracture. Obviously, bad example, but you can't think that way. How do we assess the pain in a baby? A 6-month-old. It scratches your head. Is this baby hurting, or are they hungry, or do they have a wet diaper? Is it a hair tourniquet around their toe? It's really hard, isn't it? Because they can't talk to you. They can't tell you what's going on. And the hysterical mother or father certainly won't help you either. How do you quantify the pain? Is it an 8 out of 10, 2 out of 10? How do you get a demented patient from Wakefield Commons or from the nursing home to tell you that their pain is 8 out of 10? They're not going to say. The fear of addiction, distress, the legal restraints. Or fortunately for you and I, the Congress passed, what year was that? Recently, I think it was it was the late 80s, early 90s, 1990, I think. There was an act of Congress that was passed to protect EMS providers nationwide in providing narcotic analgesia for your patients. Prior to that, the FDA and Congress had passed a Controlled Substances Act of 1970, and Richard Nixon was president at the time. His big thing that he put Pat Nixon in charge of was to get rid of the drug problem in the United States. And the outcome of that was the Controlled Substances Act of 1970. That's why we have schedules. We have Schedule 1, drugs that aren't out there for our use, heroin, that sort of thing. Schedule 2, which are the opiates that we use, fentanyl, morphine, dilaudid, oxycodone. Schedule 3, which are somewhat addicting, is phenobarbital, benzodiazepines. Schedule 4, that's things like cough syrups with codeine at very low doses. Schedule 5 is pretty much things down the road that could be habit forming, but are more psychological than physiological. So that's how that all came about, just a little history lesson for you. So 1970, the act of Congress that passed Controlled Substances Act, and then that was modified in the late 90s, I think it was. Now you and I can use opiates in the field for acute pain, which is awesome. So you don't have to worry about this and just plain old ignorance. Unfortunately, there are some of us, some of my colleagues that I've worked with in past, that just totally ignore pain. They just don't treat it. I've seen that happen in my residency training when orthopedics would change a dressing and they wouldn't give anybody for pain. I've seen that on burn units, even where they strip the dressing and irrigate the wound without analgesia. I've seen doctors in ERs set dislocations without pain medicine. So it's brutal. It's really, that's Civil War, you know. And even in the Civil War, they used chloroform, morphine, opium, and what was the other one? Oh, I can't remember. There was a fourth one that they used. Fifth one was a stick in the mouth. So, what influences our bias in the way we treat pain? Lots of factors enter into this. The age of the patient. How many of us are hesitant to treat a 6-month-old with acute pain, not knowing exactly what to do? It's a little easier now that we've got Brozilo tapes and we carry acetaminophen and ibuprofen. We can dose them according to their weight. Well, how about the 92-year-old that's polypharm and their pharmacy list is 22 medications long and they're on an anticoagulant? Now what do? Do we safely give them a drug? They're already altered. They're confused, out of it, lethargic, but they have an open femur fracture. Do we treat that pain safely with fentanyl? You know, so you start asking yourselves those questions. So age entered into it. How about genetics? There are certain people that are addiction prone. You have no way of knowing that, but word of mouth or frequent calls to the same address, you start thinking that way. Certainly culture enters into this. Unfortunately, there are cultures around the world that have less pain tolerance than other cultures. I won't point anybody out, or more, right? It's funny how when you go around the world in different pockets, there are people who do not tolerate any kind of pain at all. Some tribes in different spots of the world view pain as a curse, you know, from satanic forces or from bad spirits. Native Americans used to believe that way and still do. So this enters into the treatment of pain. There are some cultures that will not allow us to treat the pain. There are some religions that will not allow us to treat the pain because they feel that God has inflicted this for some reason and they need to work through it. You know, I don't know about you, but that's not my God. That's not how he works. Emotions enter into this. You and I both know by now that pain is both a visceral and somatic thing as well as an emotional thing. The reason is because the pain centers of the brain are right in the hypothalamus, in the midbrain. And guess what? The hypothalamus is also responsible for our emotional centers. So there you go. It overlaps it because it's all right there. So if Tyler, if I shouldn't pick on you, but if I whacked you with a ball bat across your shoulder, you'd start screaming in pain and you'd be emotionally upset. You might be angry with me or crying or whatever. So your emotions would play into your pain. Or some people actually put on that, you know, I'm tough, I can take it, you know. And so a lot of patients will hide their pain. You know, they can have acute appendicitis and no, I'm fine. And they'll just mimic or they'll downplay their pain. That can be dangerous too, because we just don't know what we're treating. And certainly social, you see how these all overlap. Social barriers interfere with our pain too. And there's lots of social circles out there that will want more pain or less pain. This is a Stephen King character probably. Let's go through some myths. A narcotic is going to affect the outcome or the competency of my exam. That has been scientifically disproven. Surgeons used to get after us all the time in emergency medicine for giving their patients morphine, Dilaudid, or whatever it was. Oh, you'll blunt my exam. Now I won't elicit a McBurney's point for acute appendicitis. That's baloney now. That will not affect your decision making. A narcotic will not change your physical exam on abdominal pain. A narcotic will not cause respiratory arrest. You and I both know from experience that you have to dump a boatload of narcotic into somebody to arrest them. And what better hands to be in if they have an adverse or a paradoxical reaction to fentanyl where their chest gets tight, or if you give them morphine and they tip the balance because they just took some heroin or something. You and I can handle that, right? Yeah, we're trained to do that. I tease patients all the time if they're in that kind of mood. Man, I had this allergic reaction, blah, blah, blah. And I said, well, you're in the right place because if you stop breathing, we're ready for that. And they look at it like, am I going to stop breathing? No, you can't tease all the patients like that, but it's fun. If I give them morphine, if I give them one shot of fentanyl, 50 mics, because they've twisted their ankle and it looks like a break, they're going to get addicted. You and I both know that's a myth. Now, there are certain very small percentages of the subpopulation that are very addiction prone. So if they take one hit of heroin or some similar substance, they can get addicted. Keep in mind that that is very, very, very minute. So the majority of the population and human population around the world will not get addicted. Analgesia means relief of pain and without the loss of consciousness. If I give somebody a medication and induce loss of consciousness, that's called anesthesia. So there's a difference. Anesthesia is putting them asleep, and we use moderate to deep sedation or anesthesia in the emergency department for reduction of shoulders, for synchronized cardioversion, that sort of thing. If I give them analgesia, you are giving them, we're relieving their pain or deadening their pain a little bit. How do we do that? We eliminate the source. So if the source of pain is, let's say, a heavy object leaning against the leg, if we pull it off the leg, it takes away some of the pain. If the cast is too tight, I saw down the sides of the cast, I do a bivalve, lift the cast, the pain goes away. Patients feel tremendously better. If the patient comes in and they're compartment syndrome, we do a fasciotomy, instant pain relief. Pretty amazing. So you eliminate the source, you block or attenuate pathways by transmitting pain to the brain. And that's where those drugs come in, because every drug works a little bit different in those pain pathways. And I'll get more into that in a little bit. So that's how they work. Everybody wonders, well, why does that work? So non-pharmacologic, you guys know what this is, RICE, right? That's rest, ice, compression, elevation. That's what we do for a minor injury or even a serious one. You want to compress, that's a splint, that's an ACE, that's a pillow and tape, whatever you can get your hands on. Elevate the extremity as best you can. And you want to use ice unless there's some contraindication for that. Pharmacologic, we're all familiar with, self-explanatory. None of us will be operating in the back of an ambulance. If you are, I'll pull your certification. And then we use physical modalities. You guys use these all the time. This is a backboard sometimes. If you're suspicious of a fractured vertebrae, why not? You know, you're immobilizing the back. That's a good thing to do. If you suspect a pelvic fracture, you're going to immobilize the pelvis, right? You're going to do a hair traction splint on a femur fracture. You're going to do an ankle splint, etc. You guys are well trained in this. How about if somebody's in pain from an acute laceration, and the laceration is bleeding like crazy? Hemorrhage control's number one, right? But when you put a pressure dressing on there and then elevate the extremity, you will alleviate pain as well. Because by doing that, you're decreasing blood flow. The blood is bringing in nourishment to the nerve fibers. So if the nerve fibers decrease their nourishment, guess what? You'll decrease the pain. Wow, that's pretty cool. So sometimes with children, it's just a matter of a hug, a cradle, a warm blanket, a pacifier. Sometimes with our behavioral health patients, it's the weighted blanket to keep them from pain and anxiety. Sometimes it's the wrap. For any of you parents in the room or grandparents, you know, sometimes with a baby, if you take that receiving blanket and wrap it really tight, they stop crying. Funny story, and I'll tell them myself. My daughter Rachel, when she was a baby, of course, you know how it is, all babies end up sleeping in the bassinet in the mom and dad's room. So Rachel was having a rough night, crying on and off every 2 hours, waking up. Finally, I leaned over and I got up and I started moving the bassinet into the walk-in closet. Lori wakes up and she goes, "What are you doing?" I said, "I'm putting her in the closet so I can get some sleep." "No, you're not." She got mad. I thought it was a great non-pharmacologic approach, but it didn't work. I almost lost my place in the bedroom for that one. So this one, you know, we talked about that. And so what can we do pharmacologically? It has to be safe. It has to be effective. It has to be quick in onset. Minimize side effects, of course. We don't want it to have any potential to really do harm to our patient. In medicine, I'm sure you've heard this before, but one of the dictums in medicine, and we got pounded into us in medical school from day one, is the Latin phrase primum non nocere, which means first do no harm. So that's where we got to start. Am I going to do harm to this patient by giving them X, Y, or Z? Will I do harm by transporting to the hospital? Will I do harm by not transporting to the hospital? You guys ask yourself this same question every time. You may be doing it subconsciously, but nonetheless, we always ask that question. Every drug that's on your rig has met this criteria, because this has to be not only statewide, but nationwide. So you can rest assured that this has gone through a lot of fingers and brains before it ended up in your toolbox. So you don't have to worry about it. A lot of new beginners, especially in the new paramedics or new EMTs just graduating, are a little bit nervous about using medications like this. They've been well taught didactically, but now you guys know the real world is much different. So am I going to push this too fast? Am I going to push this too slow? Is it going to work? What happens if it infiltrates? What happens if the patient has a reaction and your mind starts going stir crazy? So rest assured you're going to do okay. So here's what we have in our bag. We have opiates. You guys know this. Non-opiates. This is a cool term. I'll get to that in a minute, what that means. This is good old ketamine. Ketamine is fairly new to a lot of EMS agencies in the last 10 or so years, but it's an old drug. It's been around for a while. Benzodiazepines we all know about, and I'm listing them as an analgesic. Isn't that weird? Even though our protocols don't really suggest it, it's more of a second line. When you're giving midazolam to a seizure patient, you're relieving some of that pain that they're feeling because of the myoclonic activity. So that's why I threw it in there. NSAIDs, you're all familiar with. This is ibuprofen, ketorolac, like Toradol. Acetaminophen, which is kind of sort of a non-steroidal, but not. This has a different mechanism of action. I'll tell you about that. And good old nitroglycerin. I put that on there not because we use nitro for general pain, but we use it for cardiac pain. Except if you're experiencing one kind of heart attack, which is an inferior wall, right? More on that another time. The ABCDEs of assessment. Have you guys heard about these? Maybe a long time ago. Ask about the pain regularly. When you assess the patient initially, then you give them fentanyl. Now, are you going to ask them how their pain is after you give them the fentanyl? 5 to 10 minutes? Yes, you are. How'd that work? Is that working? Do you need more? And of course, some of the patients will say, why, yes. But ask them how their pain is doing. Assess that pain. My pain started in an 8, now it's a 6. My pain's an 8, now it's a 2. We do that on chest pain patients all the time. You give them the nitro, 5 minutes, how's your pain? Wow, you took it from an 8 to about a 4. I think I'll do all right. Believe the patient. One of the hesitancies of some of my colleagues and some of the nurses and techs and so forth is that hesitancy to believe the patient. They have a history. They're a frequent flyer. They have an alcohol abuse history. I don't care what the excuse is. And I myself, sometimes you have to really consciously push that bias aside. You've got to believe the patient. If they're telling you it's a 10 and their vital signs are stable, you kind of sort of have to believe them. But this is where you get to make the choice, non-opiate versus opiate. There are some choices there. So take them for what it is and just weigh everything in a big picture. Choose your pain control option which best fits your patient and makes you the most comfortable. Is there a magic textbook on what you choose and how you choose it? Really not most of the time. Some of you are habit forming and you're locked into certain ways that you treat pain, and that's fine, whatever you feel comfortable with. But I just want you to try to remember to think outside the box a little bit and tailor make your analgesia to the particular patient and the situation. Deliver intervention in a timely, logical way. Don't delay. If you get to the scene, you do your scene assessment, of course, safety and all that. And then after your initial assessment, you want to treat that pain. Obviously, now, don't let me steer you wrong. ABC first, airway, breathing, circulation, positive, hands down first. If a non-breathing patient, who cares if their femur hurts? They need to breathe first. So you know what I'm saying. So deliver pain medicine. And remember, in some circles, it was taught that pain is a vital sign. Do you remember when CMS pushed that really hard? And that's where I think the crisis began with the opiate crisis we have today, because the government was pushing this. Your health community, you need to realize that pain is a vital sign. Pain needs to be treated. So all primary care was on board with this. That's when the manufacturers of OxyContin and MS Contin just went overboard, and pockets around the country, towns were just getting inundated with this stuff. And you've seen the stories of these small towns like in West Virginia and Appalachia that are nothing but addicted people because their prescription writing was going stir crazy. So don't, just a side swipe on that. Enable and empower your patients and your families to dictate to a degree what they need to help them feel better. If they don't want you to treat it, fine, but reassess it. If they want only Tylenol, fine. If they want a little narcotic, tell them you'll start at a lower dose if they feel comfortable with that. Just kind of tailor make it to your situation. How do you assess pain? You guys know as well as I do that your eyes and your ears are some of the best tools that you can have. You, with experience, know that when you go to a scene, you can sum up in a matter of minutes what's going to go on. You know what's coming down. You walk in there and you see the 82-year-old with diabetes, hypertension. You may not even know that yet. 82 clutching his chest, diaphoretic, and he looks like he's going to pass out. You can assume that that's something life-threatening, right? And pretty soon into his history, within 5 minutes, you know it's an MI or other things. So watch the face, watch the parents, see what happens. Now, I'm not going to go into these in detail for sake of time, but I thought I'd list them. And that way, when you guys go back to the recording or you can look them up, there's pain scales. Most of us use the face for children. You've all seen it, like the smiley face to the frown and the grimace. And for adults, we use the pain scale. 10 out of 10, the worst pain you've ever had in your life, and 0, no pain at all. So some patients will say 11, redirect them, that's off the scale, it doesn't work. So these are just different scales. Why are these here? Because they have been validated in the literature. There's correlation between what we score and what the patient's pain is. So just so you know. Now, this is the nitty-gritty. What can you do at the scene and in the back of your rig? You can tell me whether the heart rate is too fast or too slow, if they're flushed, if they're diaphoretic, restless, hypertensive, tachypnic. These are standard raw data, vital signs that no one can lie with. You can't fake tachycardia. You can't fake diaphoresis. I'll tell you right now, if a patient's diaphoretic, you got trouble. Diaphoresis is not a really good sign, unless you're just plain old sweating from a hot and humid day. You guys know as well as I do, diaphoresis is different than just sweating on a hot day. Sweating on a hot day, you put them in the ambulance, it's air conditioned, wipe their brow, they're fine. If they're diaphoretic, truly diaphoretic, you wipe their brow, they're in a cold sweat. They're actually shivering, they may be cold. Diaphoresis can also happen with fever when they break their temperature. So these are obviously direct physiologic observations that you can happen. Let's go through this really quick. The OPQRST ASPN system. This was new to me when I researched the topic on pain. O is for onset. When did it start? Provocative. You ask these questions routinely anyway. Provocative. What really provoked your pain? Well, it wouldn't have been the fact that I dropped the bowling ball on my right foot. Now, would it? Okay. What's the quality? Is it dull? Is it aching? Is it sharp? Is it electric, knife-like? Because those descriptions can help you in that table I showed you, kind of place where the pain is. Where is it? It's in my right upper quadrant and it radiates up into my shoulder and my neck a little bit. And it started about 40 minutes after I ate a hamburger. What do you think it is? Gallbladder, right. It's somatic pain from the gallbladder. Could be pancreas, could be duodenum, maybe, but that you know is visceral pain, right? It's coming from the gut. Severity. How bad is your pain? Rated on a scale. This is where you use the face scales for kids, 8 out or 10 out of 10 scale for kids or adults. Timing, when did it start? Oh, it's been there for 6 months. Really? You know, but it got worse today. Oh, it just started 2 hours before I called you. What are associated with the symptoms? Classic MI pain is chest pain, dull, radiating up into jaw or neck. It's often associated with, you all know this, nausea, vomiting, diaphoresis, dizziness, lightheadedness, syncope, shortness of breath. There's other things in the chest that can do that too, PE, tension pneumonia, you name it. So get some associated symptoms with the pain. Why? Because it helps you and it helps me to figure out why they're having pain, where the pain is coming from, and how we can fix it. What's important, not only are the positives, but the negatives. If you have a headache, important negative is this the worst headache of your life? The patient says no. That kind of steers me away from an acute epidural or subarachnoid hemorrhage, right? Thunderclap headache, on the other word, is something to worry about. Or a pertinent negative, is your headache associated with any stiffness of the neck, nausea and vomiting, or fever? Oh, I haven't done none of that. Oh, good. That kind of steers you away from meningitis. Have you been traveling recently? No. That's good. That kind of steers you away from a tropical disease causing a headache. Have you been out in the woods? Did you get a tick bite in the last few weeks? Well, yeah, I think I did. Your headache could be Lyme's, maybe a rickettsial disease. So pertinent negatives are very, very important too. At the end, I give you a pertinent positive. So let's go through some medications. I hope I might be going over our magic time only because we got started late. So morphine came from the Greek god Morpheus. Did you guys know that? It was pretty cool. The Greek god Morpheus was the god of sleep and dreams. Now, why would they name morphine after the god of sleep and dreams? We all know morphine does what? Not only kill pain, but yeah, it gives them that trip, that euphoria. Ooh, I feel good. Morphine, more for me. Yeah. So that's how it got its name. It's one of the oldest opiates we have. It was discovered and formulated in the 1800s. And yes, it comes from the opium poppy, the same flower, same seeds that make heroin. Now, Morphine is not as potent as heroin. Heroin's about 50 times more potent than morphine. So you can imagine why heroin addicts like heroin, because it gives them that euphoria, makes them feel good and forget everything, and sometimes go to sleep, go to real sleep, you know. So morphine is an opiate. It comes from the opium poppy. It's not only used for pain, but we use it to reduce preload and afterload. It's a weak vasodilator. So that's why patients, when they get morphine, they drop their pressure. Pretty interesting. And all of us have seen it. Have you seen hypotension when you give morphine? Yeah. How fast does it work? We all know this from field experience, less than 5 minutes. Peaks about 20. But interestingly enough, sometimes the half-life is up to 7 hours. So good to keep in mind, because even though we reverse opiates with Narcan, that's why it is important to bring them in and have us kind of take a look at them. We usually keep the patients for at least an hour or so to make sure they're not going to have kickback. Most of the time, this isn't true, and the metabolite has very, very little effect on the brain like the active drug. So once morphine is metabolized, it's not as active because the metabolite doesn't work as well. Contraindications to morphine is if they're already in shock. Obviously, if someone has an open femur fracture, suspected pelvic fracture from an MVC, for example, you get to the scene, they're hemorrhaging and their blood pressure is 80, that's hemorrhagic shock. You're not going to use morphine, you'll probably use fentanyl, which would not drop the pressure, really good. Obviously, pain control is splinting, air traction splint, and hemorrhage control and lots of fluids. Overdose is not likely for your end, but if they have already overdosed on a narcotic and they're complaining of pain, you may want to think of a non-narcotic approach just in case. And everybody knows those side effects. Morphine is anywhere from 2.5 to 10. Most of you know this. The reason I'm putting these on is just a review. That's what we're here for. You may need to repeat the morphine. I think is protocol every 15 minutes for morphine. I'd have to look. Exactly, yeah. But everybody knows opiates are reversed with Narcan. Now fentanyl, where'd fentanyl come from? It's a synthetic. It was created in a laboratory in the 1960s. Two scientists developed this to get less side effects and more potency, so we would use less drug. Now, why is fentanyl measured in micrograms instead of milligrams? Is because 1/1000th of a milligram of morphine is a milligram of fentanyl. I'm saying that correctly. See what I'm saying? So 1,000 micrograms of fentanyl is a milligram of morphine. So that's how potent fentanyl is. Fentanyl peaks very quickly and it lasts only a half an hour to an hour. That's why you have to repeat it. I do know, because I looked in 2.13 of your protocols for pain, fentanyl can be repeated once in 15 minutes. So you can give it again. Contraindications are very similar to any opiate narcotic. It has very little effect on vital signs. That's why EMS uses fentanyl a lot. Some of my colleagues and the nurses will remark, my goodness, they use a lot of fentanyl. Well, my goodness, they're treating a painful patient. If a patient comes in and their ankle's in the wrong direction, they need fentanyl. If they're complaining of 8 out of 10 abdominal pain and vomiting because they've got a twisted bowel or bowel obstruction, you bet they need fentanyl. So you do you, and we'll let the criticisms just rest in the corridor. It can make these patients very lightheaded or dizzy. This is a rare side effect. Chest restriction is a paradoxical reaction to the synthetic. No one really knows why, but the chest literally gets rigid. Patients can't breathe. So we have to BVM through this. I've never, knock on wood, I've never had a case. But now that I've opened my fat mouth, I'll probably get one. You guys know this, 50 to 100 mics. You can start with 25 in the real skinny or the elderly or the very young. Can I use fentanyl in children? Yes, you can. And it's weight-based in kids. Don't ask me right off the top what the weight milligrams per kilogram is. Head injury caution here, only because it increases intracranial pressure, interestingly enough. unlike morphine, which drops the pressure, fentanyl will paradoxically raise ICP. So if you have a suspected head injury, it's probably better to go with the morphine unless they're in shock. Also in head injuries, I would not suggest using Toradol or a non-steroidal because it can increase bleeding risk. And by the way, you guys know fentanyl can be given intramuscularly, intranasally, or transdermal. Now, we don't use transdermal much in the pre-hospital setting, but you guys see patients with patches from time to time. Here are some other narcotics, and the reason I'm putting these up here, not that we use them, but just so you're familiar, there are some pockets of EMS around the country that do utilize nalbuphine and butorphanol or butorphanol. These are synthetics as well. I can't remember what years these were developed. Nubane's been around pretty much since I started practice back in the late 80s. These actually accentuate the kappa opiate receptor. There are 3 opiate pain receptors in the body, mu, kappa, and delta. These are up in the brain and all around your nerve endings out in the periphery. These actually activate the kappa receptors more so than the mu. The mu are mostly activated by morphine and fentanyl. So they work on a little bit different pain reception. So that's why sometimes these work better than morphine, and sometimes morphine works better than it. It just depends on where the pain's coming from. So reportedly, supposedly, the dependence on these isn't as bad as the other ones. Everybody knows hydromorphone. This was patented back in 1923. That's how old Dilaudid is. Been around a while. It hits bu just like morphine does. It's much more potent than morphine. For every milligram I give of hydromorphone, I'm giving them 10 milligrams of morphine. Do I use Dilaudid in the emergency room? Absolutely. I'm not afraid of it. I will try some other options first, but if the patients are really hurting, I'll reach for the Dilaudid. I often start with a 0.5 milligram, which is 5 milligrams of morphine. It's not too bad. It's a good starting dose for most patients. And they tolerate it really well. It doesn't typically cause as much nausea and vomiting, and you don't get the euphoria with hydromorphone that you do with morphine. People try to abuse Dilaudid and they do get kind of feeling good with it, but it's not as euphoric, and it certainly doesn't have the potency of heroin. So benzos for pain, you don't think of midazolam, diazepam, and lorazepam as acting on the pain receptors, but they do indirectly because the pain pathways also interact with gamma aminobutyric acid, which is a neurotransmitter in the brain that when activated, it slows down pain. So when the benzos interact with this pathway, guess what? Their pain goes down. And we all see that when the anxiety drops with administration of lorazepam. We give midaz for patients undergoing RSI. There's 2 reasons for that. One is to get them relaxed, to relax muscles. Number 2 is to decrease their pain reception. And we're acting on these receptors rather than mu and kappa. So it's pretty interesting. It also decreases the excitation of anxiety. Remember, physical and emotional overlap. So if we're hitting both at the same time, you're giving them fentanyl, maybe a little midaz or whatever, you're actually bifolding the pain, helping them out. Caution, very much use caution when you're using benzos with opiates, because they help each other out. It can suppress respirations and make them a little bit more groggy and lethargic. So, especially in the elderly, extremes in populations, got to be careful. So I can't find anywhere in the protocols currently where you are permitted to use benzodiazepines for pain. I think it would really have to be a one-on-one med control issue for sure, for certain. I only want you using benzos as they're indicated for seizures, alcohol withdrawal, and there's a third indication, I think. Status epilepticus, that's one thing. Okay, so just keep this in mind. It might be something that'll come down the road whenever Massachusetts catches up with the rest of the country. I don't know. Now, what about ketamine? Ketamine is a non-opiate. It's a really good choice for pain. We'll get into it in just a second. Ketorolac or Toradol, Great drug. Whoever invented this, you know, kudos. I'll buy them a steak dinner. Great drug, very effective in pain use. It's non-narcotic, non-addicting, won't make the patients lethargic. You can use it and they can drive home and manage the checkbook. Oral NSAIDs, we all know this is over the counter, ibuprofen and stuff, and acetaminophen. Now, acetaminophen is not a non-steroidal. It has analgesic properties as well. Interesting, all three of these drugs do have antipyretic properties. What that means is they control fever. So we've got extra tools in our toolbox to help with fever as well as pain. Why is that, Dan? Because the hypothalamus, here we are again, that's where your temperature center is. The temperature center is right there. So everything kind of overlaps. Take out the hypothalamus, the patient dies. So ketamine was first described in '66. That's how old this drug is. Yes, my friends, I was just a little lad back then. 3 years after Kennedy was assassinated. It's a hypnotic. So this makes hypnosis. It makes the patients sleepy, groggy, kind of out of it. And you'll see their eyes dance back and forth when you give them ketamine. Don't let it creep you out. It's an analgesic. That's why we're talking about it. And it's an amnesic. When the patients are giving ketamine, they won't remember the procedure. We can reduce the dislocated shoulder. We can sew up the face on the child that got bit by a dog. And we can remove the foreign body from the nose without the child flailing and screaming. And we don't have to traumatize the parents and wrap the child in the papoose board and they're screaming the whole time. It's very frightening. Little ketamine and no one remembers. You know, it's really good. Here's an NMDA I promised I'd tell you about. N-methyl D-aspartate. If any of you know me, you know I'm a chemistry geek, sort of. That was my major in college, so that's got me into medical school. But aspartate is a very common body chemical that's in the body in cells. It's a byproduct of protein metabolism. And when we put a methyl on the D isomer and put a nitrogen group on it, that's what this drug is. This is a neurotransmitter that is activated or put into motion, so to speak, by the ketamine. Also, ketamine works on opiate receptors and muscarinic. It would take me a whole lecture time to tell you what that means, but in simple terms, this stimulates the sympathetic nervous system or parasympathetic nervous system. It makes patients sweat. It can increase bronchosecretions, and once in a blue moon, it can make them tight in the larynx. So those are things that you may see with ketamine. We see it at larger doses than the small doses you'll be using for pain. But that's why we stimulate parasympathetic outflow, and as a result, that's what happens. So that's what you get. And then the sympathetic outflow is what causes the heart rate to go up and the blood pressure to go up. Ketamine actually will cause hypertension in some people. So there's a reference in your protocols. This is the dose, IV or IO. You all know that anything you give IV, you can give IO, correct? So repeat the dose every 15 minutes and go gun. Yeah, you can use it intranasally. Have any of you in the room used it intranasally? Yeah, just like fentanyl, it can be done that way. I haven't, but some of my colleagues have. Now, what is a non-steroidal? It's just a non-steroid. That's all that means. Prednisone, dexamethasone, butamethasone, those are all steroids, and they interface with inflammation in the body. The non-steroidals do the same, but instead of being a steroid with side effects and suppressing the adrenal gland, these chemicals actually block the production of prostaglandins from the white cells. Prostaglandins is part of a whole inflammatory cascade that creates pain. And for those of you that may have gone through paramedic class at the Mount, Kyle, if you're there, you're listening, you know what I'm talking about in pathophys. We talked about that, remember, the inflammatory pathway. So that's how these work. And they block cyclooxygenase that produces the prostaglandins. Great drugs. Ibuprofen, ketorolac does that. Diclofenac, there's all kinds out there that can do that. So they decrease pain and inflammation. And then the aniline derivatives. Aniline is actually an artificial medication that's been widely used since the early 1900s, I believe. The first drug of the aniline derivatives was called paracetamol, which is still used in Europe. We call it acetaminophen or Tylenol. The first company to mass produce it, put their name on it, Tylenol, came from McNeil Labs, and the name stuck. So anytime we see acetaminophen, no matter what the manufacturer, it's always Tylenol. So aniline derivatives are widely used, and we use these for pain and fever all the time. Can you use Tylenol with Toradol? And the answer is yes. The double T combination works really well for pain. So if you have given your patients acetaminophen and they're not feeling much pain relief, you can certainly complement it with ketorolac. I use it for kidney stone pain all the time. So that way they're not getting any narcotic analgesia, but they're getting a lot of analgesia there. Now, here's an interesting fact. Because ketorolac has non-steroidal properties, it inhibits prostaglandins. What do prostaglandins do to smooth muscle? They constrict smooth muscle. So by blocking that constriction with Toradol, ibuprofen, or whatever, guess what? They get pain relief. That's why Toradol works so well on gallstone pain, kidney stone pain. So if you have a patient you're suspecting visceral pain with, Toradol is a great drug. It's a good place to start. So in summary then, about a third of our calls pre-hospital are pain related. Everybody in the room knows that, right? So you can almost guarantee a pain related call every time you're on duty. We have the tools in our bag to relieve some pain and suffering. I would encourage all of us to do that with an open mind and good proper assessment, and to be familiar with the tools in our toolbox. Okay? And the slide. Any questions on any of that? Hey, Tom and gang out there, do you guys have any questions at all?
Dr. Wilson, a quick question for you. We
Yeah.
have a patient that we pick up periodically. He has all over pain, and we believe it's due to him not getting his regular pain medication. Either he's run out of it or whatever. And every time we go and pick him up, he's demanding narcotics for his pain management. Besides Suboxone, is there anything else we could possibly do for this, this patient to alleviate his pain? Because we transport him, and he's like screaming in agony that he needs pain medication. He's actually saying particular medications by name. We get him to the hospital, and unfortunately, because of his situation, he's not given anything. So what on our side, especially on a basic level, can we do for this type of patient?
Yeah, that's a tough case, and there's a few patients like that out there. I think the basic level or an EMT, there's not a whole lot you can do. Can basics give acetaminophen? Yeah, good. So it's unfortunately you're gonna have to tell them that's all you can, because I don't think basics can give narcotics. It has to be paramedic. But acetaminophen can be given. You can offer them Toradol. You could offer them ice. Sometimes putting ice on the abdomen over the solar plexus right at the base of the sternum. Sometimes that interrupts pain fibers, believe it or not. It's kind of a reflexology tool. The Chinese have used it for centuries, where they put ice or pressure over the solar plexus. Another hot spot for that is at the base of the neck. Sometimes that helps, depends on where the pain is, or on the inside of the ankle. It's something really cold. Some patients will respond to heat a little bit better, but that's hard to do in that setting. But it's just an option. Unfortunately, there's not a whole lot you can offer them. Just get them to the hospital. And the pain receptors in that kind of a patient are so burnt out and overutilized that it takes much more in the way of narcotics to make that patient comfortable. That's a problem with narcotics over time. The receptors become numb. So this dose of morphine sitting at the mu receptor, after a while of being bombarded, the mu receptor kind of recedes, if you will, and it just doesn't receive the morphine very well. I hope that answers your question, but there's not a whole lot of tricks in the bag.
Yeah, I figured as much, but I just figured I'd throw it out there and see if you had a possible answer for it.
Yeah, yeah, thanks. Good question to ask, but yeah, you're doing the best you can. We're just talking into no transport. That'll work. But yeah,
I
unfortunately,
mean, this particular patient will tell him that, it's like, well, we could transport you. We can't give you any medication. And they'll say, well, I want the medicine truck then.
oh yeah,
Yeah.
yeah, medicine truck. It's unavailable, or this is a BLS call. We can get you there quick, but it's going to take a lot longer for the medicine truck, to get there and reassess that pain. You're going to have your pain longer if you wait. If we get you to the hospital, it'll help you quicker.
It sounds a lot more like this patient has more of a psychological dependence now into pain meds, which that's nothing we have is going to fix that. That's time. That's also getting yourself clean and finding less narcotic based ways to fix whatever underlying problem that started it.
That's 100% correct, right? Because the emotional center now has taken over. They're used to the euphoria that they've gotten with the opiates, and yep, they're psychologically hooked. That's the biggest barrier. I notice a lot of addiction specialists tell me that that's the biggest barrier hurdle when they're going through rehab. The physical part they can get away from in a few days. Same way with alcohol, but it's the psychological that they have to work through. Good. Any other questions? You guys have been so patient with me. If you don't mind, what I'll do is I'll switch over the slides to I actually put some cases on slides. I hope you didn't mind, but that way everybody can see the cases instead of me reading them. And that way, there are a few less than usual. So if you don't mind, Tom, we could still code the sessions as a 2-hour, 1-and-1. Yeah, as a separate thing, just like we always do.
Absolutely.
Even though we had technical trouble at the first, so. All right, now let me switch. Oh, yeah, that's a good question. Yeah, Tom, are we okay on this same link, or do you have to send another link?
I sent out 2 links, one for the first hour and one for the second.
Okay.
So would you like us to switch to the second link for this?
Just for the legal aspect of the, so OEMS can't, come down on us for anything.
Yeah.
All right, we're going to do that now.
All right, ditto.